Morning, everyone. We're going to wait just a little bit more so we can get a couple more people on this call, and then we'll begin.
Good morning, Rich. Good morning, Catherine.
Hey, Charlotte.
Hey, Charlotte.
Everyone have a nice weekend?
How about you?
Yeah, really nice.
It was nice weather.
Beautiful. Yeah, beautiful weather. Hi, Kuan-Fu.
Hey, Charlotte, how are you?
Good. How are you?
I'm very good.
All right, I'm just looking over the list. I think we've got almost everyone on. I'm just looking to see. I don't see Katie on yet. So while we're waiting for her to join, we're going to be doing a little bit different schedule today. I don't know if you all saw it on the invite, but we'll flip things around. We're going to get a brief update from our matcha team about kind of what the situation is regarding COVID in Zambia right now. Then we'll have our presentation of the week from KFC. And then we're going to have a discussion about sequencing led by Jared and APL. So I think I'm a little worried about time. Edgar, are you able to give the presentation? I'm not seeing Katie on.
Yes, Katie shared the presentation. I can.
She has it.
She
just joined. Okay.
Okay, she has.
All right, perfect. Hi, Katie.
Hi. Sorry,
we're going to have you guys. No worries. We'll have you go ahead and start with your presentation, and then we will move over to KFC in Taiwan.
Okay, I actually had to join from my phone, so I can't share the slides.
Okay, I can share it, and then Katie can talk.
Okay, thanks. I think we just want to pull up the WHO graph, slide 5.
Oh, just slide 5?
I think so. We're just giving an update on the COVID situation.
Okay, you have that one? Can you see it?
Yes.
Go ahead. It's all yours, Katie. You can explain what you wanted to say.
Oh, Edgar is giving the update.
Okay.
Okay, thank you. So as you can see from this slide, Zambia is experiencing a third wave, which is much more devastating than the second wave. So in terms of positivity rate, over the weekend we had recorded, I think, about 16% positivity rate, but we are back to 20% as the update was given today. And with some of the regions like Eastern Province, Northern and Western Province, with positivity rate exceeding 30%. So Southern Province, where we are, the positivity rate was at 12%. So in terms of vaccines, the AstraZeneca vaccine is still being given. And so far, we are expecting, the government is expecting about 4.4 million doses of the J&J vaccine. So in terms of sequencing, I checked the G site today and I found that there are about 692 genomes from Zambia. And with regards to the third wave, it appears the B1617.2 is predominating. It's being driven by this Delta variant. So I think I can end there unless there are some questions.
Thank you, Edgar. Do we have any questions?
Edgar, how's matcha itself doing in the outbreak?
Matcha itself is also hit. We had a number of cases, including employees from Matcha Research Trust. We had to shut the labs for some time, and we just reopened last week. So even here, we have a number of cases.
Well, hopefully everyone stays safe. Thanks for the update, Edgar. If you have any other questions, maybe we can hold them to the end. KFC, are you ready to go?
Yes.
Okay, all yours.
All right, I hope you can see my screen well.
Yep.
All right, good. So I'm happy to share with you some of our research progress recently. We're going to start with the database management, which is going to be presented by Jean, and then the outcome analysis, some of our sequence task, machine learning task, and I don't think I have time to share with you some of our systematic review meta-analysis as well as phase-arm mix task. So Jean, would you like to start?
Okay.
Oh,
Okay.
yeah, go ahead.
Next page, please.
Yeah, so we're gonna Jing is going to share with you in terms of the missing data and outlier and how we recommend to deal with the revisit.
Okay. Hi, everyone. For the analysis of REDCap enrollment data, we pre-process the data and we focus on several outcomes, and pneumonia is an important one. And we found that there are two kinds of variable in REDCap that makes the following analysis more complicated. And later, Dr. KFC will have more detailed discussion and discussion for you. Next, please. Okay, and for the missing data, we have cleaned up some of the missing. For example, in the weight missing, some of them are pregnant or children subject. And in the current symptom fever degree, if they have no fever, then they will have no record in fever degree. And for the follow-up site, there will be large amounts of COVID groups, so maybe they are in following up, so they haven't done the follow-up yet. So it's not QC yet, so there will be some missing data here. Next, please. And also we have cleaned up the outlier, and we have changed the unit of degree into the correct degree of Celsius, and we have replaced the outlier, for example, 999 or 999.9 into NA. Next, please. And also we have found a different pattern in different cohorts. For example, in active and prospective, we have to find the ED chart review data. We should find different variable in these two cohorts. And also in patient enrollment and microbiology results is only in perspective. And we have found that in microbiology results, there are some of the data we cannot tell which body parts are the specimen for culture from. There are about 27% of the data that we cannot tell if the specimen is from respiratory tract. Okay, next, please. And also we have found that in Johns Hopkins and in Chang'an, there are different ways to filling the ED patient if they are admitted after the enrollment. In Johns Hopkins, the data will be in inpatient child review, but in Chang'an, the data will be in data enrollment child review data. And in passive and retrospective, there are different patterns to show the outpatient or different medical visit data. In retrospective, the data will be separated in rows. So to combine these data, we have solved this problem so far. Next, please. And also for the severity evaluation, we have defined a new variable revisit to see if the duration of two ED visit are less than 72 hours and 3 days in inpatient. We will define it as a revisit, and in ED is about 3.9%, and in inpatient is about 0.2%. And here's the overall question we have found when we process the data. And next, Dr. KFC will have more detailed surveillance and progress to share with you. Thank you.
Thank you, Jing. So, all these efforts to make our outcome analysis possible. So I'm going to again start with the operational definition to compare different definitions of pneumonia, and then present some of our prelim analysis in terms of the multi-level analysis. So for diagnosis of pneumonia, we know that clinical feature is very important. Patient with symptom and sign as well as laboratory evidence will be indicated to the pneumonia diagnosis, but these alone are not sufficient to support diagnosis. So sometimes we also have microbiology evidence, but again, these are not always available. So we often rely on the radiography evidence. As indicated in 2000, which is like 20 years ago, IDSA indicated chest radiograph as a gold standard, but nowadays these are considered maybe a low standard. And sometimes in radiograph, the radiologists have different description in terms of the pneumonia findings, such as consolidation and infiltrates. So we compare the different diagnoses both at Hopkins and Chang'an. And on the very right one is the overall data. We can see that ED diagnosis contribute to the most of the diagnosis since we enroll patients from the ED. But sometimes when patients are admitted, they will have some of them will have diagnosis that they didn't have in ED. And sometimes patients will be diagnosed with pneumonia in their follow-up visits. So these are not very consistent, especially the pattern at Hopkins and Taiwan is very different. Then let's take a look at the radiograph evidence. So again, in overall data sets, we can see that infiltrates, consolidation, and sometimes we also have another variable called suspected pneumonia, which indicate the radiologists clearly identify the suspicion in their reports. And this pattern is more commonly found at Hopkins, but not in Taiwan. And then when we put it all together, in the past we used the clinical diagnosis or radiograph diagnosis. So you can see the pooling circle over here is that Hopkins has a more consistent diagnosis in terms of the clinical and radiograph diagnosis. But again, these are not perfect diagnoses. So if we use this definition to see if we can tell that the patient outcome will be different, we can see that patient has clinical and radiograph diagnosis are more likely to be admitted to the hospital. And briefly, the follow-up diagnoses are more commonly seen at Hopkins, as well as the pneumonia suspicion and the success rate. And in Taiwan, the clinical and radiograph diagnosis are more discrepant. So how to deal with this discrepancy? So we've been thinking about to define different phenotypes of pneumonia. So like the sepsis diagnosis has been revised in 2016, the clinician or the researcher attempted to bypass the ambiguous diagnosis of sepsis and just try to see if we could define better using some score or some system just to find out the patient with higher risk developing bad outcome. So some of the score we are pretty much familiar with is the NEWS score, which stands for the National Early Warning Score. I developed in 2012 using only respiratory rates, oxygen saturation, oxygen usage, body temperature, the systolic blood pressure, heart rate, and the coma scale to predict cardiac arrest and some bad outcome, including anticipated ICU admission or death within 24 hours. And now we also have NEWS or NEWS 2 available. And also in 2012, we also have another severity score developed solely for patient with influenza infection. They only use age, gender, number of comorbidity, pneumonia, dyspnea, and confusion to predict mortality, mechanical ventilation, septic shock, ARDS, and resuscitation. But they also have the problem to use a relatively subjective diagnosis of pneumonia in their study. Other conventional scores are also available, such as QSOFA and CURB-65 on REDCap. And lastly, we want to see if the unsupervised machine learning could help us to do some phenotyping. So we use latent class analysis as well as hierarchical cluster analysis to see if we can better identify the phenotype of pneumonia. So among those influenza positive patients, we use the latent class analysis. As you can see in the slides, we use a symptom and past history, including influenza vaccination, exposure history, as well as some of the past medical history. And these patients could be very different in terms of their symptom distribution, except the cough, because cough is almost 90% higher identified as a symptom in our influenza confirmed patients. So using those cluster identified by latent class analysis, we can identify different subgroup as the first group as the oldest patient population, and also the highest QSOFA score and CURB-65 score. And most of the patients are African American. Later, we use the hierarchical cluster analysis to see if we can better identify the patient with a certain phenotype. So here, the 4 cluster is the best one to fit the data. So we can see in the 3rd class, a patient our oldest have the highest NEWS score, QSOFA score, CURB-65, and they most likely to be Asian, and then most likely to have severe infection. So this could be a better way to identify severe infection. Other than the unsupervised method, we also compare the sites. Now I'm shifting gear to the multi-level analysis. As I shared with you in the past, we try to see if the time is an important factor to consider when you are trying to use a symptom to diagnose a patient with influenza. So these are the attempts that we try to tease out the contribution of the control group, which means that the influenza-like illness other than influenza might contribute to our previous illustration, because we were trying to use the odds ratio to see if the symptom on different days of illness could be associated with or predicted of influenza infection. But here I just want to illustrate that you see the proportion of the symptom, or you can say the sensitivity of these symptoms. You can see that cough and rhinorrhea is very consistent throughout the course in Taiwan. Then in US at Hopkins, cough is still very predictive of influenza, or very sensitive to diagnose influenza in our data, our cohort. But shortness of breath and cough up with sputum instead of rhinorrhea are consistent symptoms indicated of influenza infection. We then try to see if the pattern of association between severity and some risk factor could be different from site to site. So now we can see that, for example, age was positively associated with the severity score using news as a surrogate score in one of the branch in Taiwan, but not the case on other branches in Taiwan and as well as Hopkins. But for education, this is another interesting finding that education is associated with severity in some of the branches, including Keelung sites and Bayview Center, but not the case for Johns Hopkins Hospital and the Lincoln branch. And we also find some different association for body temperature. I'm going to skip those slides just to let you know we are in the progress to analyze the site difference between different symptoms or race distribution and the severity and the outcome. But I do want to share with you some of the multi-level analysis, some of our preliminary analysis that we try to tease out some of the confounding factor and want to see that whether influenza B is associated with, again, the new score. And here you can see in the multivariable random effect model, influenza B compared to other type of influenza was associated with 0.5 point higher score of news indicated as severe influenza infection. And the intra-class correlation increased from 7% to 50%, which also supports our approach, try to take into account the intra-class or intra-sites correlation in our core study. And lastly, I'm going to present you some sequence and machine learning tasks we've been doing recently. One of them is a survey of SARS-CoV-2 in a region which is Taiwan without many domestic clustering in 2020. So this is a manuscript published by Dr. Gong, which is also our collaborator in our team. And we obtained 20 viral sequence, and among them we identified the RF8, which is associated with the Middle East imported strain, and we illustrate that we can contribute to the global surveillance in this manuscript. As you can see on the right, the red dots stand for the sequence we have in Taiwan, which is very evenly distributed in different clades at that time. We then try to apply our machine learning technique to first predict the neutralizing antibody and then the lineage for patient with COVID-19 infection. First is again Dr. Yuno and our colleague. We try to use the spike protein and the RBD obtained from ELISA to predict the viral neutralizing test in order to save some time and protect our colleague. So utilizing the generalized additive model, we are able to predict the antibody with 0.9 correlational coefficient in this study. We then shift gear to the pangolin in the pangolin effort. Pangolin stands for the phylogenetic assignment of named global outbreak lineage, which is applied to classify genetic lineage of SARS-CoV-2 by implementing a quote-unquote dynamic nomenclature technique. They basically use the maximum molecular base assignment algorithm first, and then shift to the classification tree since July 2020. So the gap in knowledge is whether their model is doing perfectly, or whether we can apply to our influenza studies. So the MLI comparison, we use about 4,000 sequence of SARS-CoV-2, and then using the sequence as well as the dates, and on different training, validation, and testing data sets, using the grid search technique to fine-tune our hyperparameters, and then try to multi-class to predict a multi-class in this data set. Because of the multiple lineage class in this data set, we have up to 192 class in this data set. So some class has very few lineage. So we try to reduce the classes to number more than 10, 50, or 100 sequence in that class, which stand for 3,000 or 22 or 2,300 sequence. And then we compare different machine learning algorithms. And here's our prelim results. As you can see, we have some attempt for a decision tree as well as a random forest for all sequence, and we found the performance is not very good in the testing data set. When we reduce the class to those with a higher sequence in that class, we found that these models are doing okay. But for the deep learning model, one of them is the multi-perceptron layer, and the other is the long short-term memory model. They are doing quite well no matter which class you chose. And we also try to interpret the trees by first is plot out those decision trees, but I don't think you can read those trees very well. So using the chef value to see that specific feature impact on the model outputs, we can see the different contribution of the different sides, base pair, and to see their contribution to a specific lineage. For example, the alpha strain, the B1.1.7, could be identified by those sides of base pair. And for random forest, it's also possible to interpret the model by using a similar technique. And we can also use different shape plots to see the positive or negative contribution of a specific sites. Lastly, is for the long short-term memory, it's not possible to have a similar plots, but we can see that the long short-term memory are doing quite well in this confusion matrix. And our fine-tuning technique is very good, and you can see the training and validation model are not very different. So then we try to apply those techniques on our data set, but unfortunately we don't have a big enough data set yet. So again, we are using some reference sequence, and we are also using a date as one of the feature on the similar data set and a similar technique to find the hyperparameter. And now we also only have 5 subclasses to predict. And you can see the rainforest is doing okay with sequence only or the dates as additional features in this prelim experiments. As again, we can try to see easily of the certain contribution of certain sites of base pair. And that's pretty much I have for today. I'm especially want to thank our team, especially Dr. Wu, and most of the data scientists who are not actually paid by Sears. And then also want to give thanks to Andy and Rich for the long-term collaboration. I'm happy to answer any question that you might have.
Thanks so much, KFC. Do you have any questions?
KFC, on the clinical scoring systems, can you state like your overall goal for that project? I mean, it's interesting data coupling all of these different scoring systems, and I shared a recent paper actually from Taiwan on critically ill ICU scoring systems and validation of some of those. Can you just state like what your overall objective is, and in relation to, I guess specifically I'm asking about like what the gold standard criteria you're using as your outcome is?
Yeah, Rich, thanks for a great question, because influenza is a minor illness, so sometimes it's not easy to do some prediction with a better gold standard such as sepsis, because mortality, although mortality is also not a good outcome, I think it's best to use, because between infection and mortality there's sometimes some time gap, and sometimes there are many different type of intervention that might exist between infection and mortality. So sometimes the response to treatment is another good outcome to identify. And I know that we do have some serology data that we could potentially incorporate into those severity outcome analysis in the future. And we can also incorporate the information from the virology, say the sequence information, that we could try to tease out the host factor, the pathogen factor, and better to see, we could either to identify better way to identify the phenotype, or try to see if we can develop better way to treat our patient. But for our database, I think we can also, our purpose to do this analysis is also to find out a better outcome, instead of just simply using pneumonia or one of the severity score. And I mean, that's the short-term goal, is find out a better way to identify outcome for our team. And the long-term goal is, of course, using Sears data sets as well as other data sets such as our National Health Insurance Research Database, or the database in our system. We can also try to see if we can identify a better way to phenotype our patient. So I don't think I answered your question, right?
Well, I guess my question is, like, you showed all this data comparing Hopkins and Taiwan, and I'm assuming that's multi-year from patients we've enrolled across multiple seasons.
Correct.
And you're attempting to look at all of these different scoring systems and say, you know, what compilation of scoring systems may work best for identifying clinically relevant outcomes. My question is, are the what's the objective gold standard criteria you're using as your outcome? Are you saying like X number of days of hospitalization, complications, death, or what's the standard that you're using as a comparator?
Yeah, I guess that's a good question because we haven't think that far because we are in the very beginning process. So yes, those could be some of the better outcome other than the scores. And yeah, I don't have a good answer for you now, but this could be our future objective. Yeah, I think so.
Right. Yeah, and the influenza B data is kind of interesting, and I'm working on those edits, and I'll share that back around on the paper that Alex worked on that has, I think, like 4 years of data looking at clinical outcomes of people with influenza B, looking at the potential impact of co-infection.
Mm-hmm.
Anyway, thanks for sharing all of that.
Thank you.
All right. So unfortunately, we've gotten a little pushback today, so I'll have to ask that any other questions be sent to KFC over email, and we'll jump over to our sequencing discussion. So thank you, KFC.
Thank you.
And Jared, I'll let you take it away.
Okay, can we all see this?
Yep.
Or no? The PowerPoint? Is it everything or just the PowerPoint?
Just the PowerPoint window on your now it's the full slide. Yeah.
Okay. We can move through this pretty quickly. So thanks, Catherine. And this has come up through a couple of discussions with a number of people. And so we want to talk about like what the next steps are with SARS-CoV sequencing. We have another, I don't know how many more months, 8 months, 9 months on an option, and we've kind of hit a lot of the milestones. So we were hoping to open the discussion to what the next